Thank you all for joining us today as part of the Department of Genetics and Genomic Sciences specialty webinar series to discuss common pediatric referrals to medical genetics. My name is Cassie Mintz, and I'm an assistant professor in the Department of Genetics and Genomic Sciences. I completed a combined residency in Pediatrics and Medical Genetics, and I also completed a master's degree in genetic counseling and worked as a board-certified genetic counselor in pediatric cardiology prior to starting medical school. My clinical focus is evaluating and guiding management of children and adults with a concern for genetic disorders or with a diagnosed genetic condition. And I have particular interest in growth disorders, dysmorphology, and reproductive genetics. I'm also leading our department's telegenetics initiative, and our goal is to expand access to genetic counseling and genetic testing throughout the healthcare system. So if your practice is interested in talking more about that, my contact information will be available at the end, and you should feel free to reach out to me. Please enter any questions in the Q&A box below, and I'll be answering questions at the end of the session. You should also feel free to suggest any topics for future webinars or provide specific feedback to me. And we're having these webinars monthly. Just so you know, the next one coming up will be December 16th, and one of our cancer genetic counselors, Leah Zaretsky, is going to be talking about considerations in cancer genetics for transgender patients. If you want to see any of our prior webinars, they're also uploaded on our department's YouTube site as well. I have no conflicts of interest to report for this talk. So the main goal of this webinar is to review common indications that should prompt thinking about referring a pediatric patient to genetics, and also to review the different options for genetic testing, think about some of the important factors for interpreting genetic test results as well. And then finally, I have a few cases that I hope will be interesting and illustrate these points. So the main reason to refer a patient to medical genetics and to consider genetic testing is to discover a unifying diagnosis for the patient or to confirm a clinical diagnosis. And knowing the molecular genotype can help with prognosis if there's any known genotype-phenotype correlations, which unfortunately is not always the case. But it can also be helpful just to think about some common health concerns that a family has to look out for, arrange appropriate evaluations with a specialist. And in some cases, we do have treatments such as enzyme replacement therapy to either slow down the progression of a disorder or to avoid known complications of the disorder. Another important aspect is assisting with family planning. So if we know the genetic diagnosis, we can think about whether there's any testing that can be done in a future pregnancy for a family, or even testing before conception with IVF as well. And we can also identify other family members who may be at risk. Having a genetic diagnosis also helps identify appropriate research if patients are interested in that. And finally, it can also help find appropriate support groups and resources for affected families. And I think especially for families who have a child with a genetic disorder, it can be really helpful to reach out and be able to talk to other parents with older children who have already gone through some of the health concerns that that family is going through with their child. So when I think about the different types of genetic disorders, these are really the different categories. So when we think about chromosomal abnormalities, we're thinking about a problem with the, or an abnormal number of chromosomes or a problem with the structure of chromosomes. And everyone is very familiar with trisomy 21. 22q11 deletion syndrome is also in this category, as well as more rare translocations, which are structural abnormalities. And then there are a host of monogenic disorders where we know that a single gene not functioning properly causes specific symptoms. And examples of those are achondroplasia and cystic fibrosis. There are also imprinting disorders, and these often have to do with growth and development. So I think they are important to think about in the pediatric population. And in this case, the symptoms that a patient has or their phenotype is determined by whether the abnormal or non-working copy of a gene or group of genes is inherited from the mother or the father. And the one that really comes up the most, I think, clinically is Prader-Willi syndrome and Angelman syndrome, which are disorders on the 15th chromosome. And then we also have disorders that we say are multifactorial or polygenic, where there can be a group of genes kind of interplaying to produce a phenotype, or there might be some susceptibility in genetics that interacts with the environment. An example of that is cleft lip and palate. So these are some of the most common referrals that we get to medical genetics, and by no means is this all the indications to refer to genetics, but some of the most common are developmental delay in autism, dysmorphic features, having abnormal growth, and that can include tall or short stature for the patient's genetic background, multiple congenital anomalies, congenital heart defects, early onset hearing and or vision loss, refractory seizure disorders, and progressive neurological disorders. And I have a few cases that will go through some of these indications, but again, you know, there are a lot of monogenic disorders that have specific phenotypes, and we get referred a lot of other things aside from just these, but these I think are the most common that come up. So just a few things to kind of highlight in the normal pediatric evaluation that might lead you to think about if a genetic disorder is present or what testing a patient may have already had. So the prenatal and birth history can be very helpful, specifically if any genetic testing was done during the pregnancy. It's possible to do genetic screening with mother's blood or diagnostic testing as well through amnio and CVS. So that's really helpful to know about. If there's any abnormal ultrasound findings, that can be a clue. It's important to know if carrier screening was done for parents and kind of the level, how many genes were included in a carrier screening panel, as well as the age of both parents. So we know I think it's commonly known that as maternal age increases, there's an increased risk for chromosomal disorders like trisomy 21, but actually with advanced paternal age, there's also an increase in the risk for new mutations in autosomal dominant disorders. So father's age is important too. And then some things that should kind of be a red flag for if there could be a genetic disorder present in the newborn period is if there's hypotonia, feeding difficulties, and it's important to know whether the newborn screen had any abnormalities or not. Growth measurements can also be a clue as to whether something genetic might be going on. So again, if there are growth trends that are not expected for the family, and again, that could be very tall or very short stature as well. And also the head measurement can really provide a clue. Some disorders are known to have small head size microcephaly, and some disorders are known to have a larger head size macrocephaly. Development also is very important. And again, thinking about a genetic syndrome more when you have more severe developmental delay, global developmental delay, and certainly if there's any regression of developmental milestones. When we think about exam findings, again, it's really a constellation of findings. So thinking about whether there's multiple abnormal features versus an isolated anomaly. And again, if multiple organ systems are involved, that would be more concerning for a genetic disorder. And then finally, of course, when we talk about genetics, the family history is really invaluable. So thinking about, could any of the family members, even with maybe some mild symptoms or features be affected. And it's important to remember that not having any family history doesn't rule out a genetic disorder. Certainly for autosomal recessive disorders, we don't expect there to be a family history. And even for autosomal dominant disorders, many times you can have new mutations. So lack of a family history, even if both parents don't appear to have any symptoms, it's still something to keep on your radar. And finally, we always ask about whether there's a blood relationship between the parents or anyone else in the family, so consanguinity. And if there is, that can just kind of clue us in to think about some specific autosomal recessive disorders, since there's an increased risk that the parents could be carriers for rare mutations from a common ancestor. So once we get to the genetics visit, I wanted to talk a little bit about what we do and kind of what's unique to our visit. So for the physical exam, I think what's really unique to us, again, is the dysmorphology assessment. So we look at, you know, every part of the body. We do a lot of specific measurements. You often see us talking about the inner canthal distance, the outer canthal distance, which is highlighted in this picture here. And then we have some books, such as the Oxford Handbook of Physical Measurements, where we can really look at, based on the patient's age and these different measurements, where they fit on the spectrum of normal. And again, we're looking for multiple clues that are all coming together to think about a specific syndrome, but any one variation, you know, does not mean that something is a problem with genetics. And then again, because the family history is so important, we take a 3-generation family history to see if there's any possible inheritance patterns that we can elicit from the family. And finally, we're going to be thinking about what genetic testing is appropriate and counseling the patient on the risks and benefits of that genetic testing. So I wanted to go through the different genetic testing tools that we have. The first, again, that I think most people will know about and know pretty well is the karyotype. So that's on your left here, and that is looking at all the chromosomes in each cell of the patient's body. So we're looking to see, is the number of chromosomes correct? We can see the sex chromosomes. And we're looking to see if under the microscope we can see any abnormalities in either the number or structure. Another thing that can be done is a FISH test, and that stands for fluorescence in situ hybridization. And so that's actually if you have a suspicion that there could be a deletion, for example, in a specific area of the chromosome, and you could have probes that specifically look at that area. So what you're seeing in this picture here is looking for 22q11 deletion. So you can see that there are 2 probes that are hybridizing to the 22nd chromosome, and this is normal. You see both sets of probes here, but on this one, you see that the green probe hybridizes, but you don't see the red probe, and that's telling you that you're missing part of the 22nd chromosome, and we know that that's specifically looking for 22q11. The next step in evaluating the chromosomes at a higher resolution is to do a microarray. And so in this case, again, we're looking for deletions and duplications, and we call them microdeletions and microduplications because they're too small usually to see just by looking under the microscope at chromosomes. And this looks at the patient's DNA compared to the test DNA to see these very small copy number variants. I also wanted to, at this point, just bring up methylation studies. Again, as I mentioned, you know, thinking about Prader-Willi syndrome and Angelman syndrome, it's very common that these come up on our differential for any growth disorders, developmental disorders. So I did want to just point out that there is specific testing that can be done separately to determine whether a change or a problem in this location came from mom or dad. So now I want to get into, we talked about cytogenetics and looking at the chromosomes. I wanted to talk now at the gene level to look at sequencing of the genes. That's kind of our next step of of tools that we use. And again, this is helpful if you have a specific gene in mind, a specific monogenic syndrome. And then we'll also talk briefly about whole exome sequencing, which can look at all of the coding regions of the genome. So this is actually looking at the sequence of a specific gene to see if it's as expected or if there's any known mutations in a patient's sample. One way that we could do this is panel sequencing, where there's a pre-selected set of genes that are known to be associated with a particular phenotype. For example, there are microcephaly panels that can have, 50, 100 genes, sometimes even more, that we know microcephaly is a major feature in a change in that gene. This needs to be updated regularly as new disease genes are discovered. And then we also have exome sequencing, which is being used more frequently now, and that's sequencing of all the exons of the genome, so all of the coding regions. The variants in the genes are then filtered by the lab based on the described phenotype or symptoms of the patient. And this can help us identify changes in genes that maybe didn't initially come up on clinical based on the suspected clinical presentation, but that there is some evidence in the literature that it could be related to our patient's symptoms. So it does really help, especially when maybe we've done some other tests that have been unremarkable and unrevealing for a diagnosis. And then genome sequencing is really the most comprehensive at this point. So this is looking at both exons and introns, so the non-coding parts of the genome as well. And this is really mostly used in research settings currently. There are higher costs associated with it. They're looking at more data, so there's greater computational requirements, and it's not regularly covered by insurance at this point, although some companies are starting to offer this on a clinical basis. So I wanted to talk a little bit about the importance of informed consent and some of the things that we discuss with patients when we talk about, whether they might want to do genetic testing. So a lot of patients want to know what kind of sample it is. We're usually doing a blood draw, but we can also do a buccal swab or a saliva sample. And sometimes we have to do a skin biopsy. Especially if someone has a history of hematological malignancy and we can't use their blood sample. That's one of the reasons we would do that, or if they've had a stem cell transplant, for example. We always talk about costs and insurance coverage, and the majority of the labs that we use will do a benefits investigation to let patients know whether they would have any out-of-pocket cost before running the test, because of course we don't want patients to have a big bill at the end of this testing. There are emotional considerations, especially when we're talking about children. If we find that something is inherited from a parent, there can be feelings of anxiety, guilt, depression, so that's important to consider. And then we always talk about any incidental or unexpected findings that can come up. For example, on microarray, we can see if there's a certain percentage of the chromosomes that are very similar, that there's a potential for a blood relationship between families. So we do always mention things that might come up, so people are not surprised. And then we also spend a lot of time just talking about that even if we find, a genetic diagnosis, it doesn't always tell us, exactly what the prognosis or what health concerns would be predicted for that patient. We don't always know, if the patient will show symptoms of a disorder, what the severity would be, or how quickly those symptoms might progress. And then this is a little less important for children, but I just wanted to make note of the fact that there are some genetic protections, some legal protections related to genetic information. So in 2008, the Genetic Information Non-Discrimination Act, or GINA, was passed. And this makes it illegal for health insurance providers to use any genetic information to make decisions about health insurance eligibility or coverage. They can't give different premiums because of genetic information. And for adults, it also does protect from discrimination for employment as well. It doesn't apply to other forms of insurance right now, so disability insurance, long-term care, or life insurance. So when we're talking about, testing a child's parents, for example, or testing adults, this is something that comes into play. So once we have, once we have these genetic changes in a gene, the challenge really is figuring out what that means clinically for the patient. So there are guidelines that have been put out by the American College of Medical Genetics, and these provide guidance to laboratories for how to classify genetic changes. The only changes that are going to be reported on a clinical lab report are either pathogenic, so known disease-causing mutations, likely pathogenic, and again, based on the different criteria, that's how they're categorized. So in likely pathogenic, there's over a 90% chance that it's disease-causing. And then most laboratories also report out what we call variants of uncertain significance, where there's really not enough evidence for or against whether that change is causing disease or if it's just normal variation in the population. And that's what gets a little difficult when we are giving results back to patients. We do always talk about this and talk about how we would handle those results. And usually that means testing family members to help us interpret an uncertain result. So this is basically what we go through with patients when we're doing these sequencing tests. And as well for the microarray, we could sometimes get variants of uncertain significance as well. So we talk about getting a positive result where we know that that change causes a genetic disorder. We've seen it before, or it's a change that we expect would prevent the gene from functioning properly. And those are changes where we can provide good guidelines for management and surveillance for health concerns. That also allows us what we call cascade testing, so testing of other family members who are at risk, and to think about recurrence risks and reproductive options. A negative result, that means that the results looked as expected. We didn't see any changes. It's still important to think about, at this case, any residual risks for a genetic etiology. So even though we've looked at, a certain number of genes, there are genes that are, still being discovered. There are genes that are still being associated or finding new associations with different phenotypes and different conditions. So it's important to note that even if, a test comes back negative, that we're not testing everything, and that we still have to think about in the future whether there's additional testing that should be done as technology advances and as gene discovery increases. So we may recommend in that case follow-up for a patient in 1 to 2 years. And then finally, for variants of uncertain significance, we do family testing to help us interpret that result, but sometimes we still really just can't say, again, whether it's normal variation or whether it might be causing the disorder. And in that case, we do recommend strongly follow-up in 1 to 2 years to see if there's any advances in knowledge of specific variants. And sometimes these variants are reclassified. So a VUS, as there's more people tested and more information, they might be downgraded to benign. And sometimes we have more information, more strong information to say that they are pathogenic and disease-causing over time. So I really wanted to end here, and I'll answer any questions that come up, but just to review, put a list up for you again of the most common indications. And then also to remind you that, there are multiple other monogenic disorders. So while I focused on mostly developmental delay, dysmorphic features, and abnormal growth, that there are also many other reasons to refer patients to genetics. The last thing I wanted to show you, especially for any students who are viewing this webinar, are some good resources when you're thinking about a genetic disorder. So omim.org is great to look up clinical information and research on specific genes. Gene Reviews is really great for a summary of clinical characteristics, diagnosis and testing, management, and genetic counseling for genetic disorders. And then especially if you have one feature where you're thinking, you know, what should I be thinking about? Could this be a genetic condition? The Oxford Desk Reference is a really great resource. I don't have any association with any of these websites or books, but they've really helped me. So that's a great one. If you see, for example, if you see macrocephaly and you're wondering what else should I be asking about in the history, what disorders are associated with it, the Oxford Desk Reference has been really helpful. Finally, I just wanted to let you know about our team. So these are our clinical geneticists, and we have 3 wonderful genetic counselors. If you have patients that you'd like to refer to us, you can do a consult to medical genetics in Epic. Patients can also call this number here, and this information will go out to you after the talk, so you don't have to worry about writing it down if you don't have a pen. But they can call to schedule an appointment. We also have telegenetics consultations available when it's appropriate, and otherwise we're located in the Atrium building on the 1st floor. And finally, again, we are really working to increase access to genetic counseling and genetic testing and genetics expertise. So if you have an interest in how this can fit in with your practice, please feel free to email me. And thank you again for everyone for attending and listening today.